Okay, everyone, we're going to go ahead and get started. Thank you so much for joining us on Investing in Community Health, part of the Big Sky Care Connect annual conference. I'm Mary Windecker with the Behavioral Health Alliance of Montana. If you have any questions during the presentations, please just put them in the chat box and we'll answer as many as we can as we go through the afternoon. Our beautiful home of Montana is made up of 1 million people spread across almost 150,000 square miles. Providing care to this far-flung state has long been an issue. As the days of the single general practitioner who helped patients from birth to death have faded and specialty care has expanded, it is even more difficult to address the comprehensive needs of Montanans. We are number 3 for suicides in the nation, dropping from number 1, less because we improved than because other states got worse. We have a high rate of children in foster care. Our opioid and methamphetamine rates are at epidemic proportion, and alcohol continues to be the number 1 addiction in our state. We have high rates of avoidable diseases, diabetes, heart disease, addiction, emphysema, etc. By 2025, the largest demographic in the state of Montana will be over 65. That means that our workforce will be limited, and with the cost of living increases across the state and traditionally low salaries, we will never be able to put people in every discipline in every county that needs them. We are, however, innovative and independent. We can and have used technology to provide a widespread array of healthcare through telehealth. Mental health and substance use treatment can effectively use telehealth to reach areas of our state that we can't afford to send people to on a regular basis. Due to the pandemic, the availability of treating people through telehealth and telephone visits has greatly expanded. We are working to continue to expand those capabilities in the post-pandemic world. Currently, the care in Montana is siloed. There's primary care, specialty care in both medical and behavioral health, acute care in hospitals, and too much care being delivered in emergency departments rather than at a medical home where the whole patient can be treated. As we work to make transformative change in the healthcare delivered in Montana, we have the Health Information Exchange to help us create a continuity of care rather than the current silos of care. The Health Information Exchange can do much of what was promised by the electronic health record of a few years ago. With the implementation of a different electronic health record in almost every facility, the number of silos actually were increased rather than decreased. Now with the Health Information Exchange, we hope that the promise of interconnectability and communication across the healthcare continuum will be realized. Today's panel are all experts at dealing with vulnerable populations across the state. We'll hear from them about how the HIE will help them deliver that care in partnership across the healthcare continuum. Mental health therapists can find out about a client's emergency department visit, and the emergency department physician will know if the patient they're seeing in the ER is a patient of a therapist. This scenario plays out in every discipline and across all demographics in both rural and urban healthcare settings in Montana. Just a few housekeeping matters. If you have questions during any of the presentations, please type them into the chat box and we will answer as many of them as we can. These presentations are being recorded and will be available to review after the conference. Thank you so much for participating. So we're going to start today with panel presentations. Each panelist is going to tell us about their organization, their role, the vulnerable patient population they provide care to, and the targeted efforts in place to invest in healthy community. We're going to start today with Mary Hutton of Providence Health Services in Western Montana. Mary?
Good, thanks, Mary. Good afternoon, everyone. My role here at Providence in Missoula, Montana is I'm the Community Health Investment Regional Director for Providence. And a few years ago, we here in Missoula teamed up with the City of Missoula, and we submitted a grant to the Montana Healthcare Foundation under the Housing is Healthcare name. and we received that grant. And as part of that grant process, we really wanted to refine our work, and which will define the conversation that I'm going to have to you today about a particular population that we really wanted to focus on. And that really is our homeless, high utilizing individuals that we serve here in Providence and frankly in the Missoula community. So we partnered with others in the community, the city, our homeless shelter, our other acute care provider in the community, as well as other service providers. So we, through a series of meetings, et cetera, we really wanted to hone in on understanding this high utilizing population much better than we did. Now, individually as organizations, we knew who they were. So for example, here at St. Pat's, we knew exactly who was overutilizing our emergency department, and so did the Poverello, and so did the jail, and so did the police department, and so did Community Medical Center, and some of the other entities. What we didn't have was an ability to understand who each other's high utilizing patient population was. So through the grant, we really convened this community collaborative, and we really had some decisions. We made collective decisions around wanting to have a data agreement signed amongst us so that we could share the information about who these high utilizing patients were that we all knew. Once we had that list, what we then really wanted to understand at a deeper level, what was the actual, how do we track? So it's one thing that we can compare lists, but it's another thing that how will we know if any one of our interventions have actually been successful if we don't actually have the ability to know if they've come back into the ER however many times? So what we did was we, again, had that uniform agreement about what made up, what constituted a high utilizing patient. And then we also then, for us at St. Pat's, we decided to use HIE, which is the Emergency Department Information Exchange, as a vehicle for us to be able to really better track those individuals. So what we did with HIE was a bit of a unique situation within HIE. We loaded all of those individual that panel of patients into HIE so that we then could track. So every time they presented into the emergency department, we could track that. In addition to that, given that we had this collaboration amongst our community partners, if there were specific care plans or instructions or follow-up needed for those individuals by one of our community partners, then what we would be able to do is to load that into HIE so that when they presented into the emergency department, there was a care plan, if you will, from our FQHC that the emergency room doctors could then view. And they would know, so if that, for example, if that FQHC patient had a care manager that they were working with, and that we knew that if they presented into the ED, we want that care manager called, we put into HIE the number and the name of that care manager so that the emergency department knew exactly who to call right away. And in some cases, given the time that that person presented in the emergency department, that care manager was actually able to come on site and meet that patient in the emergency department. So what we found as we really utilize this technology, it really allowed us to understand at a much deeper level the patients that are really overusing systems of care. And then as a community, we were able to really prioritize. So in other words, as we set our criteria for these high utilizing individuals, we were able to really ensure that we were focusing on the highest utilizers of multiple systems within the community. Some individuals utilize the emergency department quite a bit, but they might not be homeless. Or they utilize the emergency department quite a bit, but they're from a completely different community. So what we really found useful and helpful for us was to utilize, to one, come to an agreement within the community on how do we really want to, one, identify those individuals who are really overusing multiple systems. And then as we understood the utilization of those individuals, then how do we respond more effectively? And then lastly, as a healthcare entity, how do we track? So in other words, if we're communicating with our collaborative partners, how then can we start to really drive down the overutilization of those healthcare services and really track those outcomes? So then, and I'll finish with the last phase of this work is really to then, with our housing partners in our continuum of care and within our HIMIS, which is the Housing Management Information System, what we did is we worked with that group to be able to say, listen, we have these really, really high utilizing homeless individuals. What if we prioritized those individuals for housing? So as you can see, we built layer upon layer of collaboration and agreement amongst community partners for a very high utilizing individuals and or group of patients. So thank you, Mary.
Thank you, Mary. Always a pleasure to hear how innovative and forward-thinking Providence is in the community. It's just excellent to see you guys putting things in place. Next, we have Lynette Kozovich, who is the CEO of Rimrock Foundation in Billings and also the Behavioral Health Alliance current chair of the board of directors. So Lynette.
Thanks, Mary. And thanks to the Big Sky Care Connect for having this forum so we can talk a little bit about what is going on in our little piece of the world. And like Mary said, I'm with Rimrock Foundation, and we're an organization that has been in Billings for about 52 years. We have both our SUD license from the entire continuum of care, and we also have had our mental health license for a little over 35 years. So we have a mental health center that's actually embedded within Rimrock. Our services, like I said, we have a subacute hospital detoxification center, 12-bed. And with that too, we also have 2 crisis beds that are exclusively reserved for mental health crises. We have inpatient, we have residential, we have all the intensive outpatient and other outpatient services. Pretty heavily invested also in the court systems. We help support 5 of the treatment courts. We've probably the biggest thing that's happened to us over this last year, I'd say, just happened in the last month, and we were licensed an additional PAC team to sit here in Yellowstone County. So we're the second PAC team in Yellowstone County. And I'm already surprised with the utilization uptick in using that PAC team. I've been very involved in the Substance Abuse Connect Coalition here in Billings and Yellowstone County. It was derived through a couple of phone calls of looking to see how we could really address some of the increase of violent crime that was directly related to substance abuse. The U.S. Attorney General for Montana, Kurt Alme, really took this as a personal mission and gathered us around and said, hey, we're a bunch of smart people that have the resources, and if we pull together, perhaps we can really understand how to best address this issue in our community. It has been a long 2.5 years of intense work. And what has made it so interesting is there's so many different entities that have been involved, everything from crisis response to substance use treatment, mental health treatment, housing. It goes on and on. And I'd have to agree with Mary. It wasn't as hard as I thought it would be to identify those folks that really were the most vulnerable in this situation, and those that probably need the most help. I think we're launching some of our programs right now, and really are going through some growing pains as we get the right executive director in place and continue to work independently, yet as a coalition, as we really try to put some initiatives into place that will be long-lasting and sustainable. I think, Mary, that's pretty much what I have as far as just a quick overview of Rimrock and what we're doing.
Great, thank you so much, Lynette. Next, we're going to move to a joint presentation between Earl Sutherland and Tony Wood, both with the Montana Primary Care Association. And Tony is brave enough to try out a PowerPoint this afternoon. So thank you. I'll turn it over to both of you.
Thank you so much. And Earl, thank you so much for partnering up with me for this presentation. I promised Earl that I would not bore our group with death by slides. But I'm a very visual person, so hopefully you all bear with me as we go through our presentation. So Earl, if you wouldn't mind just kicking it off and talking about your role with the Montana Primary Care Association.
Good afternoon, folks. I'm a psychologist by training, way past my shelf life, but I keep having opportunities to do really interesting things. And the Montana Primary Care Association has offered me a wonderful opportunity to do something really interesting. And that is to work as the director of the Integrated Training Academy, specifically to provide training and increase the opportunities for integrated behavioral health and primary care throughout our state. MPC has a long history of providing training across multiple areas, and it's very rewarding to really help break down the silos that were mentioned earlier and to bring integrated behavioral health services into primary care settings.
Thank you, Earl. And my name is Tony Wood. I am the Clinical Informatics Manager for the Health Center Controlled Network, which is a grant that's under the umbrella of the Montana Primary Care Association. Our organization has a partnership agreement with Big Sky Care Connect to educate our members about the opportunity to participate with the Health Information Exchange. On our team, we have Cindy Sturgar, who is our CEO. She is on the board of directors for Big Sky Care Connect. And Leslie Southworth, our HCCN director, is on the Clinical Quality Committee. I sit on the Technology and Privacy and Security Committee. So our involvement and support of Big Sky Care Connect is pretty great because we see the benefits of having our Health Information Exchange in Montana. So the Montana Primary Care Association is the support organization for Montana's 14 community health centers and 3 of our urban Indian health centers. MPCA centers serve over 117,500 patients across Montana. Here I'm showing you a map of our health centers and their sites, as well as our urban Indian health centers. One of our urban Indian health centers actually became a HRSA designated look-alike last fall, and so they you'll see some of their numbers in some information I'm going to show you. So incorporated in 1987, the Montana Primary Care Association is a nonprofit organization dedicated to improving access to high quality, community-based, affordable primary health care in Montana. We work to support and increase Montana's access to excellent patient-centered healthcare, The association provides training and technical assistance to health centers and our Urban Indian Health Center members, and works to improve access to healthcare for all, especially for underserved and vulnerable populations. Our mission is to promote integrated primary health care to achieve health and well-being for Montana's most vulnerable populations. And our vision is for health equity for all Montanans. Our values are collaboration, integrity, and innovation. And we weave these into the work that we do every day. Health equity, just here's a little image for you. This is something we strive for. And I think that a picture is worth 1,000 words. The Montana Primary Care Association promotes health equity for a thriving Montana by promoting proactive operational and clinical peer networks. We have regular calls with our CEOs, with our medical directors, our dental directors, our behavioral health directors. We have different peer networks going on to help support one another. We work towards expanding resources, partnerships, and supportive public policies. We work to foster seamless, community-centered, accountable care through expanded horizontal relationships. Data is very important, and so we're working at providing data that speaks to the value and effectiveness of our members. And we serve communities in need to identify solutions to healthcare issues. Some of the programs that we have under the Montana Primary Care Association, Earl spoke about our the work that we're doing for integrated behavioral health. We also have Cover Montana. You know, there's a short window open right now for getting insurance to Montanans. We have a great program for Quality Data Initiative where our members self-report to us each month on specific clinical quality measures. And then we do a lot of work to help our members improve those measures, those numbers, and we learn from one another. I work under a grant for the Health Center Control Network, and I have a fun job of helping our members with health information technology around things like data, workflows. Telehealth has been a huge one, especially with our current climate. So I have a fun role in the things that I get to do in my position. And, you know, just helping our health centers with operations, governance, and emergency preparedness. So if you're interested in any of those things, there's additional information on our website. So in 2019, I mentioned that our health centers saw over 117,000 patients. And so this is kind of a breakdown of health center services statewide for 2019, just to help paint a picture. So in 2019, our health centers saw over 93,000 patients for medical visits, over 32,000 for dental visits. There are over 13,000 patients for mental health and over 3,000 patients for substance abuse treatment. One of the things that our health centers do really well is provide enabling services. And so what enabling services are is it's non-clinical services that aim to increase access to healthcare and improve health outcomes, and include services such as health education, interpretation, case management, you know, helping their patients out that might need assistance with housing or access to food. And so just, you know, this is just kind of like a quick picture of some of the services offered. Our health centers also have primary care is the main focus, but some of our health centers also have pharmacies in-house and just do a lot of work across the state. To paint a picture of health center patient income across the state, there's over 38,000 patients that are 100% below the federal poverty level. And just to give you a perspective of that, if there's one person in the household at 100% poverty level, their annual income is $12,760. For 200% poverty level, that's at $25,520. So just to kind of paint a picture of the the health center patient income across the state. I just wanted to provide that information. And then our payer mix with our health centers, we have almost 36% for Medicaid, 20% of our patients are uninsured, 17% Medicare, and then we have private and other public. Of course, that varies a little bit depending on the location, but this is just aggregate of the health center payer mix across the state. Talking a bit about social determinants of health, and this is where this is a great resource that the Robert Wood Johnson Foundation created. The social determinants of health are the conditions that impact our health and well-being, the circumstances which we were born, grow up, live, work, and age. And where we live, learn, work, and play can have a greater impact on how long and how well we live than medical care. And so this is where those services that are provided by the health centers to help the patients with their, if they're having housing issues, or if they need help with getting insurance, or if, they don't have insurance and they're a patient that's newly diagnosed with diabetes and needs some medication. There's a lot of work done behind the scenes to help the patients with their social determinants of health, because we know that those social determinants can really impact a patient's health outcomes. Just to give you a visualization, think about a clinic that has a patient population where 10% of their patient population has diabetes. And that patient population, let's say that 30% have an A1C greater than 9, or they haven't been tested. And then on top of that, 40% of those patients also have a behavioral health diagnosis. They have unstable housing, and they are below 100% of the federal poverty guidelines. So, kind of looking at that type of information for the health center's patients is really important, because, those 10% are really important, but we need to focus on those patients that have a high A1C and they haven't been tested, and those patients that have other diagnosis and are having some social determinants issue also need additional assistance. So that's something that our health centers really focus on, and try and focus on those patients really well. One of the fun things that I get to do in my role at the Primary Care Association, we are rolling out a software called Azara Drives to our health centers. Drives is a data reporting and visualization system, and focuses on clinically integrated data. So we currently have 7 of our health centers that are live on Azara Drives, and we have 4 that are in progress. And so why this is important is, from a network level, it gives us access to aggregate information for our health centers that are live on the software. We're tying it into work that we're doing with our quality data initiative, and we're tying it into work that's being done for different programs, such as Medicaid PSMH. But at the network level, we have access to aggregate information and can look and see where our health centers are doing really well and where our health centers might need some help. We're doing a lot of neat work digging in to see where there might be disparities with homelessness or race and ethnicity based upon, the data that we've had access to. So that's pretty exciting. Our health centers have access to data for daily care delivery. They're able to do visit planning. They can do population management. So they have registries available where they have patient detail. They can look at their patients and say, okay, we had, X number of patients with a diagnosis of depression, and, they haven't been in for a while. We need to, have them come in and be seen and visit with someone, so they can manage their patient population better. And then from a compliance perspective, there's also data available to help vet centers report on UDS reporting, patient-centered medical home. So there's a lot of great information available. we just kicked off this project last year. We did have one site that was a pilot for us that's been using Azara drives for a couple of years, but just over the last year, we've gone from one site using it to 7, and we have a goal of having all of our health centers live on Azara drives over the next couple of years. So just an idea of what we're doing at the PCA to use data to help our members. And it's really important for our members to have information at the right place at the right time. For our health centers to approach care as a holistic approach, our hope is the health information exchange would be a communication tool to let us know when our vulnerable patients are receiving care at other places such as an emergency department, inpatient organization for treatment, and having this information would allow the providers to have a better picture of what's happening with their patients. At this time, a lot of our health centers have employees that are doing outreach to their local hospitals and emergency departments to see if any of their patients had an emergency room visit or, were hospitalized. And those are things that really takes time and money. And so having that type of information at their fingertips where they can take action on it really would be better for the organization and for the patient. And so now I'm going to hand it over to Earl to share some stories because he has real life experience of how important it is to have information at the right place and the right time.
So one of the important things in behavioral health services is informed consent. And I would like for all of you to know that part of my informed consent is to tell you why I am a big drinker of Kool-Aid, and things like health information exchanges are really important. The conversation earlier about Eddie and then Azar really are all pointing to the same direction, that if you've been in clinical practice for a while, you've been waiting a long time for this. And that's that the more information we have and the greater access we have to that information, the better we can do our jobs. So part of me drinking the Kool-Aid is my past experience in the Indian Health Service. I served as a director of behavioral health, and then through circumstances beyond any reasonable control, ended up being the clinical director. And that experience was both with inpatient ER and then primary care and behavioral health services. And what happened is probably what many of you have experienced. We would have a patient come into the emergency room and no information about what had happened previously, what medications, what conditions. In the behavioral health world, having new patients come in, and they've been receiving some type of service somewhere before, but we have no information. So one of the things that we've all lived through with that is the patients may be in crisis. They may be at different states of difficulty. They may have some memory of what their treatment was. They may know what some of their medications were, or those memories may be impacted by their status, by their illness, by their life conditions. And we all too often end up making our best guess. And the best guess sometimes is good and sometimes not so good. The other common experience is to have someone that you've been working with that needed a higher level of care, and you forward them onward. And eventually they come back, and you may or may not have the good fortune to get any discharge information. Do you pick up where you left off? Many times a higher level of service is needed for what amounts to different types of crisis situations. Were those resolved? Is there a treatment that we should be picking up on? All of you have lived through that, I'm sure. So this is where, if we can have timely information, if we can have access to that information at ideally the time when the folks are sitting with us, or when they're coming to our facilities for service, we can all do a better job. The other side of that is the information that we had that we wanted to send with the patient that may or may not have arrived. that we may have been able to speak to someone prior to their showing up for the facility, but sometimes in rural Montana, that's pretty iffy. So having that exchange of information going both ways is really exciting for all of the reasons that I've just mentioned, but most of all because we really owe our clients, our patients, our best efforts to give them the appropriate treatment and not to have to reinvent the wheel, or when someone is seeking help to have the same 25 questions asked over and over before anything can either pick up where they felt they left off with their treatment, or we can start something new to help with that. So I'm looking forward to the Kool-Aid not only tasting good, but actually being ready, available, and able to help all of us.
Right, thank you so much, both Tony and Earl. Just a reminder to everyone that if you have questions as we move through, please do put them in the chat box and we will answer those as we get ready. So what we're going to do now is have a discussion with the panel on some conversation or some questions that we've identified, and I'm going to ask them to weigh in on some of these questions for what they see. So the first one is, what are the pain points in managing vulnerable populations in the absence of any form of health information exchange? And Earl, since you're at the top of my screen, you get to start.
Okay, let me give some very specific examples, and then I'm sure other people have them. Life in the ER is difficult enough. Life in the ER without enough information and really difficult situations is even more difficult. I often would, in my work with the Indian Health Service, would be on call and have to respond to the ER. There are some mental illnesses that can be greatly effective and helped with medication, psychotropic medications. There's some of those medications, though, that the last time you're on it has a great big impact. So in particular, one of the cases that really was very problematic for me was someone who had been on lamotrigine. That's FDA approved for stabilization on bipolar illnesses, bipolar 2 in particular. But if you've been off that for more than a week, 2 weeks, the titration schedule to come back up is very fixed. And if we don't know where someone was and you try to go back to the dose that they remembered, or the last time they remembered taking the medication, there's a very serious side effect that can happen for that. And we're all in the healthcare business because we want to do good work. Making someone worse because of our lack of information. Another example was, again, in the ER. There was an adolescent who had a very chronic and severe mental illness. Again, had probably had treatment somewhere, but was very agitated. Obviously needed something, and so our ER physician made the best call they could. Gave what was a very sensible and standard of care form of treatment, which unfortunately we didn't know that the individual had last had that medication shortly before and no family member was able to remember that. And now we're doing another intervention to stop the terrible, uncontrollable movements that are happening for him. And then last was the family who has returned, and that we sent, again, an adolescent who had been actively suicidal for treatment, and they're coming back, and they're very concerned that they don't have a relapse, and we unfortunately did not have any discharge information. What was the actual treatment plan? How many people remembered that? In times of great stress, memory doesn't function real well. And we all do what everybody does in these situations. We get the best information we can and go forward. But in those three cases, it would have been so much easier. We could have done such a better job. And most importantly, we could have done better sooner if we had access to that information on both sides.
Thank you. I think we all agree that the best solutions come out of the actual problems that people face in some of those areas. And those stories are exactly what we need to really come up with a solution for this HIE. Tony, did you want to weigh in on that question?
Yeah, Earl's a tough act to follow, but, thinking of treating the whole patient in, when we're looking at quadruple aim and in, improving outcomes for patients, if we don't have the information when we need it, there's the likelihood for, if we're trying to send patients to have a test that was already done, and for a patient with limited resources, that might not be an option, or even, for any of us as consumers. So I just think that, thinking of the staff time of folks trying to track down to see if a patient had a mammogram or if their colonoscopies come through, some of those things that are affecting outcomes for patients, I think it just will improve efficiency and allow our caregivers and staff to be able to focus on patient care rather than trying to track down a test result that they're looking for.
Mary?
Yeah, I would agree with everything that's been presented before. I would just add to the story or the example that I shared previously around the use of HIE. With our the benefits of using HIE, we now, at least within the Missoula community, are really adding to that kind of cohort of collaborators, some of the mental health providers, so that we can then, and who are coming on to HIE, so that notice, if you will, that their patient is in the ED or has been in the ED. What I would want to just add to the HIE specific conversation, and where I would say whether it's HIE or whether it's the passive communication of faxing between care providers that too often happens right now, is really that inability to have that closed loop, if you will, so that if, let's say, Earl receives a referral from the emergency department or from another care provider that's in the HIE, the promise of being able to have that bi-directional communication with that referent is really very key, because right now it's far better to have a notice of someone being somewhere and but it's even better to have that closed loop referral, so that you actually know what's happening with your patient, that they actually got to Earl for that follow-up, or to Lynette or any other provider.
Excellent point. Thank you. Lynette?
Well, I think probably if we're talking about some pain points that we have currently, when a person is in crisis with either their mental health or addiction, their needs become immediate. We have a very narrow window of time to get them into services where their motivation is there to actually receive the help. And because, riffing a little bit on what Earl said, we always want to first do no harm. And I've noticed in my own experience over the last probably decade or so, the patients that we are seeing are so sick. They're not dealing just with, either a mental health issue or addiction. They have two comorbidities. They don't have one. They have diabetes and they have hypertension, or they have, it just goes on and on and on. We've practiced obtaining medical records prior to admission, just to make sure that we are the appropriate level of care. It helps us determine the level of care that they need also. It's not been unusual over the last probably half a decade or so to see 25-year-olds that have had a heart valve replacement because of their use with illicit drugs, and may have very complicated care. We've admitted them when they've decided they don't want to take any blood thinners anymore, even though they do have a heart valve, which you know how dangerous that is. So we've always had to obtain records prior to admission. And you can imagine how that really does stall the time to get somebody into treatment. And often we lose them during that time. Either their motivation is gone, or we lose people. It's unacceptable to have that kind of issue be the barrier for people to seek care. Second thing that we see often is people in anybody's care in a behavioral health organization sometimes may have a health issue that is beyond the level of care that we're providing and may need emergency care. And in those cases, we do send them to a local emergency department. We have struggled, despite promising each other, the healthcare system and Rimrock, that we will have soft and thorough handoffs back and forth between, but we will end up having a patient come back to us and we have absolutely no idea what their diagnosis was, and the patient often isn't a very good reporter, or what kind of treatment was done while they were in the emergency department. It's dangerous. And those are probably my very biggest pain points when I think about, in this day and age, that the transference of information is so herky-jerky that we've created dangerous situations for our patients.
Thank you. I think one of the things we've heard over and over from the behavioral health providers is that the patients are much, much sicker and much, much younger over the last 10 years. And this is just going to hopefully alleviate some of that with getting accurate reporting. Next question I want to start with, and I'll start with Mary Hutton on this one. From what you know about an HIE, how will the HIE improve the situation? You've kind of answered that, but if you can just, really highlight how this will help.
Again, much of what we've had to do as we build on all of these opportunities for better connection and communication, and again, to Lynette's point, beyond the promise of organization to organization to have warm handoffs amongst each other, I think how an HIE will really, in my opinion, improve the situation is to really enable us to have that closed loop, bi-directional communication amongst providers. Because we just simply cannot rely on patients having the information readily available on them, that they remember, or somebody that's on the other end of the phone call can pick up and give you the information you need. So for me, that would be, the greatest promise of an HIE.
Lynette?
Well, if we bring it to the most recent time, I would say, boy, it'd be nice to check out to see if somebody has had a recent COVID test. It would also be very helpful, I think, for other organizations to see that every patient that comes through our door is getting one. So that, that is one thing that'll be just incredible. I think to have notifications where there has been either a primary care appointment, emergency room visit, and I just think the overall coordination, I mean, as a patient, as a user of healthcare myself, a consumer of healthcare, I'm excited about what this can offer. It's really interesting. I see a specialist and I see my primary care right now. And a huge advancement we have seen is I can see my own patient chart right now in either one of those arenas. They don't match. One says I'm a smoker, one says I'm not a smoker. And just to see how we will have the ability even if it's just shamed into cleaning up some of these charts. Again, it's a safety issue, and being able to see and exchange information that is correct and at least in some cases might elicit a question for clarification, I think it's going to just really improve healthcare.
Thank you. Good point. I'm glad to hear you're not a smoker, Lynette. Tony?
Yeah, I'm thinking back to my role prior to joining the Primary Care Association. I was the regional HIE manager for SEL Health for our ambulatory clinics. And I kind of joked that I was like the scanning police. I did way more than that. But oftentimes our practices would receive faxes that were 500 up to, 200 plus pages of outside records. And then all of those would get scanned into one lump. And really, how helpful is that? It's like, yeah, some human spent the time to send all of those pages of records over, and then they're getting lumped together and scanned into the record. But really, is that actionable? Is that helping anyone? It's just so much waste of time and energy and resources on both sides. Whereas a health information exchange could make that information available in a way that's actionable and viewable and makes sense when they need it. So, building on what you guys said, but I just think back to those days of like, really how helpful is 200 pages of documents just, scanned into a record? It's really not.
Thank you. Good point. Earl? Earl, you're still on mute.
I'm having flashbacks of when I had a 1964 Corona. And I had to point it downhill if I knew it was going to rain overnight because it wouldn't start. And I've been doing training at multiple CAUs and rural health clinics across the state. And faxing is my 1964 Corona. You can make it work, but you got to get up early. You got to push and work extra hard as opposed to just accessing it. And what I've seen in multiple locations, very small places really are the only game in town, and lots of Montana. And if the person who's used to checking the faxes every morning before the team's huddle is out, that ball gets dropped and no information is available. So, I like pushing a button and my car starts before I go out to sweep the snow off of it. And like Lynette, I'm a patient and I want people to have the accurate, right information because it's my health and my time that's being put on hold.
Great. All good points. Thank you so much. Lynette, we'll start this one with you, but what advice would you provide for individuals that have hesitancies about using an HIE? There have been a number of privacy concerns, both from clinicians and patients. So if you all can just speak to that, how safe you feel using this.
I'm going to roll it back even further. This has been a long project, and we've been very fortunate to be included near the beginning of some of the decisions as a behavioral health organization, and particularly representing BAM. The thoughtfulness of the questions that were asked of us as behavioralists or addiction treatment as they developed securities and all the back office stuff that will make it work and function the way it's expected and keep everybody's records safe was phenomenal. I was so impressed, starting with Jean Branscombe and how she knows this inside and out, and the rest of the team who has worked with us right down to the technology, asking us questions that are specific to our specialty. And it made me feel very confident that this has been done right. I have no qualms whatsoever. And I don't know if I'm out of order by even mentioning this, but even as they priced out, there's got to be a subscription fee to this. And I felt just very honored that they really how thoughtful they went through the process of pricing this out. And we're not a huge organization, and it feels very that we'll be able to afford this kind of a fee, knowing particularly it's going to improve patient care in the long run and increase safety. So it's a pretty easy spend when those two things will be upheld.
Thank you. Tony?
Oh gosh, I think that we've touched on this quite a bit throughout. I think that, just having that information is so valuable, and opening up time for your staff to be able to do the work and see the patients and take action on that information that they can get through the health information exchange, I think is really important.
Can you just speak a little bit, since you're our technical representative, on what has to happen for 42 CFR and HIPAA?
Yeah, so there's been quite a bit of discussion on the technology and privacy and security work group on HIPAA and 42 CFR, and we have some of our health centers as an example that are state designated, and then others that they treat patients for substance abuse disorder, and so that information is something that's been top of mind for us. Because we want to make sure that that information is kept secure. And the work groups have been working to put the appropriate policies and procedures in place to make sure that the appropriate information is secure. And for those sites that have sensitive information during their onboarding process can attest to that. And so then there's some safeguards that are going to be put into place. So if someone is going to access those records, they actually have to break the glass, and then there's going to be, on the technology side, logs and things like that, so that we know who's looking at the information and what they access. And so there's a lot of work being done behind the scenes. I know that there's another session, I think concurrently with this one, that where they're really diving deep into those details, but it has been a hot topic and something that we've taken pretty seriously.
Thank you. I think that just every clinician that I've talked to about this has said first thing, what about HIPAA? What about 42 CFR Part 2? So, Earl?
I want to switch hats and go from clinician to administrator because, frankly, everybody's already said all the stuff that I wish I would have thought of to say too. Patient care is first and foremost, but if we can't keep the doors open, if we can't pay our bills, if we have our patients, our clients go bankrupt because of extra fees and other things, we're not even going to get close to better patient care. And Lynette touched on it briefly, but all the time to track down the information we need to do the work that should be done has a meter ticking. And frankly, we can't afford not to move forward. We can't afford not to be more efficient, not just and always, first off, for patient care, but nobody's throwing big pots of money at healthcare. Facilities are struggling. It's an uncertain time about reimbursement. All kinds of changes are coming on. So frankly, we can't afford to miss any opportunity to not only do a better job, but to be more efficient.
Thank you. Mary?
Yeah, I agree with everything that everybody has already said. And I would say too, just from that utilization perspective of patients across systems, again, being able to get it right in Missoula, and then if that patient ends up in Billings 5 weeks from now, to get it right the first time down there too. I mean, the value proposition for our patients who may not even know about the exchange, but what they will experience is a different delivery of care. And ultimately, that's really what's going to be drive, I think, the promise of an HIE is really that instead of having to repeat, or I don't know, and so we've all experienced that at different care settings. Imagine when we don't have to do that.
Thank you. I think it all boils down to quality of care and trying to provide the very best quality between all the silos out there. Okay, Tony, this is our last question. And each of you, if you want to just give me the highlights, you've had very thoughtful, great answers to all the questions. This is just, what do you see as the biggest benefit of the HIE?
I feel like the biggest benefit really is that information about the patient at the right place at the right time so they can receive the best, safest care possible.
Lynette?
I think we're all going to say the same thing. It's safety and quality and patient experience. So you're nailing some of those essential things in delivery of any type of service-oriented industry. So I think we'll all probably say something like that.
Well, let's see. Earl?
So I've learned that when really intelligent women give the best answers, the best thing I can do is just nod my head and say, I completely agree.
That's very smart, Earl. Mary Hutton, you wrap us up.
Ditto to all the other extremely smart and capable people on the panel, but I would also say that it has to be more cost effective to the healthcare system overall.
Mm-hmm. Yeah. All right. Well, thank you all so much. You've just been wonderful. Your answers are so excellent and really gave us all, I think, a lot to think about of how to deal with some of these more vulnerable populations. I'd like to ask our attendees if there's anybody who has a question that they'd like to put into the chat. We haven't received anything so far, but you get one more chance to see if there's any question you'd like to have.
Mary, this is Julie. I had a question for the panel that I was just wondering about, if I could ask
Jump in, of course.
Sure. So I know we talked a lot about just the behavioral health aspect of it and the privacy piece of it, but what about the comorbidity situations where a person comes into the hospital with the behavioral health piece, but there's all those things that come about with testing and the stress of all of that. And then you've got a person who may have just had a battery of tests done, say in Billings, and they end up in Missoula. And then there's the threat of having that whole battery of tests redone and the stress that puts on a person that the HIE can potentially avoid, because that would be there. I always think of that because I've had recently a family member who didn't have behavioral health issues, but the stress that put her under, just having to say, I just had all of these things. And her doctor was getting frustrated and saying, well, I can't get my hands on them. We're just going to redo them again. And she was just so stressed out about that. And just to imagine someone that can't articulate that because of whatever situation they're in, to have that come on them too. I just think, there's all of that goes along with the behavioral health issues, that everyone still has the physical health things that come along too. And so that piles on top of it. And I think that the HIE is just such a benefit in that aspect too. So do you have any thoughts on that from the panel?
I would agree, just because, again, if our goal is to provide holistic care and knowing how sick people are anymore, it's absolutely imperative. And again, going back to being a patient myself, when I've been asked to take another test that I know I've had in the last 3 months, and I can't produce it or prove it, right now, and the waste and the inconvenience that is associated with that is unforgivable. So I think it's going to be a huge asset.
Yeah,
And
and just
you know, I would
the
just add to that the money, especially with the high deductible insurance plans that most people have, it's coming out of their HSA if they're fortunate to have that, or it's coming out of their pocket. You know, you have to be really, really, really sick before you hit that high deductible. So the cost that it will save people, I think, is important as well. Any other questions from any of our attendees? We thank you all for attending today. Really appreciate it. And the panel members, you've just been wonderful. Delight to work with. So thank you. Thanks for getting through that PowerPoint, Tony, without asking me for any advice, because you did great. All right, everyone, I'd like to thank you all for attending and encourage you to sit in on some of the other sessions of this really valuable conference that's going on. So thank you all very much. Have a great day.